Hey guys, thanks for checking out our video. So I'm Dr. Sarah and this is Dr. Alicia, and we're two family doctors that do maternity care here in Victoria, British Columbia, and we're putting together an online series of labor and delivery talks. So this is our fourth video, and this is all about what we call the second stage of labor. So if you like what you see here, we ask you to subscribe, check out the other videos that we've put together, or visit our website, shefoundhealth.ca. We've got lots of great blog posts and all sorts of other information that pertains to pregnancy and newborn care. And we're also putting up an online prenatal course that's going to be much more detailed and provide a lot of guidance and support for you. So if you're not able to make it to an in-person class and you want to do something from the convenience of your own home at your own time with the capacity to or capability to rewatch it, because if you're anything like me, I need to watch things 2 or 3 times before I get it. Stay tuned, and we'll share the information for that as well when it becomes available.
Yeah. Also, we'll link all the other videos in our series down below in the show notes, and check out our disclaimer at the end of the show notes as well. And all of our social media handles are there as well. So, second stage. So essentially, second stage is defined from...
I'm getting excited. It's time to have your baby.
We like babies. Second stage is defined from when you are fully dilated until your baby is delivered. So this is different for everybody. If you've had a baby before, this can often be pretty quick. If you haven't had a baby before, average is about 2 hours of pushing from when you're fully dilated until we meet your cute baby. Now this can vary depending on baby's positions and your pelvis size, if you have an epidural or not. But what I'm saying is it's a lot of work and it's hard work, but you get a really cute baby at the end of it.
It's worth it.
Yeah.
We often say it's like a marathon on the inside.
Yeah.
And it is. You have your uterus is a giant muscle working away. So during this time, the second stage, we do monitor your baby pretty closely because it can be a bit stressful for that baby getting squished through and out that birth canal. And sometimes if you start to run out of steam, which can happen because it's a marathon, or if it's taking quite a while and we're not seeing that baby move down as quickly as we would anticipate, we can talk about the option of what we call an assisted delivery.
Yeah. We also do this sometimes if baby's in distress and we need to get baby out sooner rather than later. So even if you're pushing amazingly well and you're moving your baby down, if baby's having trouble and we think we can help expedite that delivery to keep baby safe, we'll offer these options as well. So the first thing that we can offer is an episiotomy. So an episiotomy, we do this actually not very often at all, is when we use scissors to cut your perineum to make more room after we've put local anesthetic in, of course. And so if your baby is at the perineum and it's just you've got a very strong perineal muscle and pelvic floor because you've been working so hard at keeping it strong, we sometimes need to help and just release a little bit of that tightness of your perineum to help baby come out a little bit more quickly. Now, the beautiful thing about an episiotomy, if you need to have one, is they're actually really easy to repair and get everything back to ish where it was before. So a lot of people have fears around episiotomies, but it's actually one of the easier things for your care providers to repair afterwards if we need to do it.
Yeah, and again, like Alicia said, it's not something that's done routinely
at all
or often. Okay, guys?
Maybe once a year I do it, and I deliver about 100 babies a year, so it's pretty rare that we do it.
Yeah. So the second intervention we might offer is called a vacuum. So it sounds funny, but basically we put a tiny little suction cup on the back of your baby's head. You still push and do 98% of the work. What we do with the suction cup is just help pull a little bit and basically guide that baby through the proper position down under that pubic bone and through the birth canal. So we only do this, if the baby's showing distress and like Dr. Alicia said, it needs to come out faster, or you're exhausted and that baby's low, but you're just feeling done and ready for that baby to be born. So we also only do it when we think there's a good chance of it working. So the baby has to be pretty low down. You've had to do a lot of work to get that baby down low enough.
We think there's a really good chance of it working.
Yeah. Occasionally, we will have to cut an episiotomy with a vacuum just because we're trying to make more space and more room. But again, like Alicia said, that's pretty rare. And sometimes after a vacuum, your baby can have a little mark on its head. One of my kids had a vacuum that fell off, and then we had forceps, which is rare. Yeah, whatever, it happens. I'm fine. I'm great. They're great. And he did have a little what we call cephalohematoma. It went away. It's non-existent. He's got a beautiful head today. So, you know, the most common reason that we do a vacuum is that either the baby's getting tired or you're getting tired, and it needs to come out quicker than we think that you can push it out on your own.
Exactly. So the third option that sometimes will be presented is something called forceps. Now, forceps are used when the baby is too high to do a vacuum, but your doctor thinks that they can get baby out vaginally, and it needs to be done quickly, or you're exhausted and you need some support to get your baby out vaginally. Forceps are essentially kind of like spoons or salad tongs, and they get put on your baby's head very carefully, and the physician helps to pull baby out again while you're pushing. Again, we only do these if we think that there's a really good chance of succeeding, and it's generally a very safe procedure. There's very small risks of sometimes bruising a nerve, which usually resolves, but that's pretty low risk. Mm-hmm. There's a bit of a higher chance with forceps that we're going to need to do an episiotomy just because there's more stuff in your vagina, so we need more room. So rather than risk a big tear, we often cut an episiotomy just to make room, and so that the tear is less likely to cause you trouble later on.
Mm-hmm. Yeah, and you know, something I often tell women about the vagina is it heals so well. So, and I sort of liken it to when you bite your cheek.
Yep.
You can feel it for a day or two, and then you actually can never tell again where that has happened.
Yeah.
That's mucosal tissue that's really highly vascularized and has lots of good blood flow. Your vagina is the same. They heal wonderfully. You know, there are those rare people who do have sort of complications and pain post-delivery, but that's really uncommon, and we want you to be reassured that despite, you know, what might happen during delivery, generally you're going to heal just fine. So, lastly, the intervention we might have to offer is a cesarean section. So, we do this for a number of reasons. If your baby's struggling, showing signs of distress, which we usually see when we're monitoring the fetal heart rate, either the fetal heart rate's going too high, dipping too low, that kind of thing, or it just doesn't seem like your body's dilating the cervix, baby's not moving down far enough, and, you know, we've run out of options. So a cesarean section is an operation during which a surgeon makes an incision down your lower abdomen. We call it the bikini line incision.
It's about that long.
Yeah. Just above your pubic bone, and you have a belly birth. So
a belly button birth, I like to call it.
So it generally takes about 45 minutes from start to finish, and usually the baby's out in the first 5 to 10 minutes. So what would happen is we would make that decision together, bring you across to the operating room, make sure you're nice and frozen, either get you a top up of your epidural or put what we call a spinal anesthetic in place, which is just a one-time dose of freezing. Yep. The nurses get you all ready, we set up the drapes, and then your partner comes in and sits with you. So after baby's out, those first 5 to 10 minutes, the pediatrician will examine them because the pediatrician's in attendance at any assisted delivery birth. Baby gets to go and snuggle with you while we put together the different layers. Yep. You know, there are risks associated with the surgery, like there are with any procedure, but those risks are really small. And typically the risks we talk about are a bleeding, requiring blood transfusion, injuries to anything that's around the uterus, so the bowel, bladder, and the tubes that connect your kidneys to your bladder, and infection. So, you know, if any of those injury happens, it can often be fixed at time of surgery. If there's an infection, we give a dose of antibiotics pre-operatively, and we keep an eye on you post-section as well. And there's also a risk of getting a blood clot in your leg. So oftentimes you'll have some compression devices on your legs for the first day or two until you start moving around.
Some people love them. Some people hate them.
But not everyone needs them. It depends on your overall risk factors. But generally speaking, cesarean sections are a safe and quick operation.
So we thought we'd go through some common questions that we often get asked around cesarean sections. So the first one that people often are curious about is actually, do you cut through the muscles? And no, we don't cut through the muscles. So the muscles run up and down. So when we're doing a cesarean section, we just spread those muscles out and then go through the layers underneath. And then those muscles, generally speaking, come back quite well together. And if it looks like they may not, some of the surgeons will actually put a little bit of a stitch down at the lower end just to help them come together nicely and heal up a little bit better.
Another question we often get is, what is the recovery going to look like after you've had a C-section? And that answer often depends on how much labor you had going into it. So most women, if they've had minimal labor or it was an elective and planned surgery, manage fine with Tylenol and Advil. And, you know, that's especially just after the first couple of days. The hardest part about the recovery typically is getting out of bed. So I don't have any experience with the cesarean section, but Dr. Alicia does here. So she's going to give you some tips.
I have the patented roll off the bed technique onto your hands and knees and then get up. Works like a charm. Also, in terms of recovery, I actually found I had a vaginal delivery and then I had a cesarean section with my second child, and I actually found the recovery for the cesarean section easier than my vaginal delivery. Now, if I'd had a subsequent vaginal delivery, that probably would have been a bit more of a piece of a cake, unless I had a second delivery like Dr. Lee and needed forceps, but that's a whole other story. The other things that we make sure in terms of recovery is you need to protect your incisions. So we usually suggest no major activity for 6 weeks, but really those first 4 to 6 weeks you should be snuggling with your baby and taking it easy and working on breastfeeding if that's what you choose to do. And after about 6 weeks you can get back into activity, walking and moving forward like that. The other thing that is a bit of a challenge is no heavy lifting. So we don't want you lifting anything heavier than your baby for those first 6 weeks as well. So sometimes if you have a second delivery that's a cesarean section, it's tough when you've got a toddler at home. So good practice is just when you're pregnant with your second, teach your toddler to climb up on the couch to snuggle you, those types of things leading up to the delivery.
Another common question we get is, if I've had one C-section, does it mean I'm going to have C-sections for all the rest of my babies? And generally the answer is no. Having one cesarean section does not mean you'll have to have all your other babies that way. Many women go on to have successful vaginal birth after cesarean section. But we do need that scar to heal up between surgeries, so we really recommend waiting at least 18 months between deliveries if you're hoping to have a trial of labor after you've had a cesarean section. The only women who cannot labor are women who have had an incision that goes up and down their uterus. That's a classical incision and usually only happens if your baby was delivered super early, like 26, 27, 28 weeks.
And you will be explicitly told after your cesarean section if that is the type of scar you want, because everybody wants to make sure that you are safe in any future pregnancies and you do not try to labor.
When you're trying to decide in subsequent pregnancies about whether you want to have a repeat cesarean section or a trial of labor, that's a really important conversation to have with your care provider as well as with an obstetrician. And generally it's safe to try a vaginal delivery after one. After two, if you've had 2 cesarean sections, we tend to advise continuing to have cesarean sections after that because you've had 2 incisions on your uterus.
So after a vaginal delivery, we'll give you some medication through the intravenous, if you have one, or into your leg, of a medication called oxytocin. This medication causes your uterus to cramp. In fact, it's the same hormone that you naturally produce during labor to get your cramps happening. The reason we give this is because we want your uterus to cramp down and cover up all of those blood vessels that have been supplying your placenta. So by cramping down, it'll detach your placenta, which we can then deliver. The placenta is usually delivered within the first 20 minutes after vaginal delivery. And sometimes if it's a bit more stuck, we need to help it along, pretty rarely, either by helping it by pulling it out with our hands or by going to the operating room. Again, this is pretty rare that this needs to happen. Most placentas detach nicely on their own and deliver nicely with just that extra medication we give after delivery.
And so then once your placenta is delivered, what we do as the care provider is we examine your perineum and do any repairs that need to be done. We'll tell you what we find, and we don't count the number of stitches that we put in. Oftentimes we do what's called a running stitch. So we put in some stitches, bring all the tissues back together. We give a good firm massage on your tummy, which honestly feels terrible. And the reason we're doing that is we want to make sure that all the blood clots that have been collected in your uterus are expressed. So your uterus can clamp down really hard and stop that blood flow that up until the time you delivered your baby was important to provide nutrients and oxygen to your baby. So after we've done that, we've pushed on your tummy, we've repaired your perineum, we're done. And you get to enjoy your baby. You're going to have your nurse keep an eye on you for about an hour really closely. Just checking your blood pressure, having a feel of your tummy every now and then, monitoring your bleeding, but she'll help you get cleaned up, and you won't be paying any attention to what we're doing because you're just going to be staring at that newborn.
And so to that point, after delivery, as long as your baby's well, your baby is on your belly skin to skin, and you guys are having some nice snuggles. A few other things that we usually do that people ask about is we do delayed cord clamping for at least a minute, which is usually when the pulsations stop. So we get as much blood as we can to your baby during that time after delivery. We always offer for your support person, partner, to cut the cord if they want to. If they don't want to, if there's somebody else in the room that does, great. If not, we're happy to do that. But baby is generally skin to skin with you at that point. If you've had an assisted delivery, like Dr. Sarah said, we always have a pediatrician in the room. So they'll give your baby a quick look over, make sure everything's fine, and then give baby back to you. Once we're done all the stuff that we need to do helping you get better, if there's been no pediatrician, we'll give your baby a quick look over, make sure baby's happy and healthy, and then again back to you. So that kind of wraps up this video, this episode on active labor and delivery and how we might need to help move that along. So if you like this video, hit the subscribe button below, check out these other videos in the same series, and check out our website at www.shefoundhealth.ca. Have a great day.